The next presenter is Dr. Kseniya Petrova-Drus. Kseniya came to us from Cornell, did her residency and her Heme Path fellowship, and then she was a molecular fellow, 2016 to 17, and joined our Heme Path team and molecular team. So obviously we're expecting Heme.
Your expectation is correct. Thank you so much for the opportunity to present this unique and interesting case. So I'm going to tell you about a patient with skin lesions that have a discrepant phenotype. So our patient is a 42-year-old woman who has no significant past medical history until in about 2017 when she presented with multiple skin lesions all over her body. So they were described as salmon-colored patches and some nodules that were present all over her torso and extremities ranging from less than 1 centimeter to about a 5-centimeter lesion on one of her arms. She was initially treated with topical therapy, but after a month she had no response, and a biopsy was performed of one of the lesions. At the outside, the biopsy was interpreted to be a myeloid sarcoma, so she came to our institution for further workup and treatment. However, when we performed the biopsy in-house, while we were waiting for the outside slides to be reviewed, our immunophenotype was not compatible with this, so this involved more extensive workup. So her CBC was unremarkable. She had no circulating blasts. There was no evidence of anemia, thrombocytopenia, or neutropenia. So a bone marrow biopsy was performed, and you could see at low power here, it's approximately normocellular to mildly hypercellular for her age. The myeloid to erythroid ratio is normal. There's adequate number of megakaryocytes. They show maybe slight atypia, but no significant dysplasia. There was no significant dysplasia on the aspirate smear of the myeloid or erythroid components. And then by flow cytometry, we found no abnormal blasts, no blasts with an abnormal immunophenotype, no increase in blasts, and her karyotype showed a normal polymorphism of an inversion 9. And a molecular mutational panel was also negative on the bone marrow aspirate. So PET imaging was performed, and you could see here that she had these scattered lesions that were predominantly in the skin and subcutaneous tissue, a couple of isolated lesions here in the bone, but no mediastinal mass, no diffuse marrow involvement. So these are the skin biopsies that I want to share with you here. So at low power, you could appreciate that there is this atypical infiltrate that appears to be sparing the epidermis and predominantly involves the dermis, involving predominantly the periadnexal structures. Unfortunately, the biopsy, so there were 2 biopsies performed, one on the left side of her body and one on the right side. Unfortunately, the right-sided biopsy is somewhat crushed, but we could still appreciate some features and better preserved areas. So this particular infiltrate was composed of these large atypical monocytoid-looking cells, or sorry, mononuclear cells that have a high nuclear to cytoplasmic ratio, and they have fine chromatin, occasional prominent nucleoli. There are scattered mitotic figures that could be appreciated. And similarly, on the right-sided lesion also we have this fine chromatin compatible with blasts. And it was CD45 positive, so it did arrive at my desk for further workup. So CD34, and a marker of immaturity, of course, was positive on the left-hand side, and also the right-sided lesion. The right-sided lesion, as I said, was somewhat crushed, so it's difficult to appreciate, but there was weak CD34 expression. Another marker of immaturity, TDT, was negative on the right-sided lesion, but had a scattered variable nuclear expression on the left-sided lesion. Significantly, myeloperoxidase, a marker of myeloid differentiation, was positive on the right-sided lesion and showed strong expression, but the left-sided lesion was dead negative for MPO, and we repeated MPO multiple times. We even tried different antigen retrieval techniques to see if this was just an artifact, but this consistently came up negative. So we then went on to complete the workup and looking for additional markers of lineage differentiation, and we see that CD33 is positive in both, so this is another marker of myeloid differentiation. Another marker of immaturity, LMO2, was positive in both. CD7, which is thought to be, consistently thought to be more of a T-cell marker, but it can be aberrantly expressed in acute myeloid leukemias. It was positive in both as well. CD56 and CD4 were positive in both as well. Then marker of T-cell lineage, CD3, was strongly positive or variable positive in the left-sided lesion, but the right-sided lesion was negative for CD3. We do see some scattered T cells as an internal positive control. Additional markers were performed for T cell lineage differentiation, which were negative. Another marker of immaturity, CD117, was negative. B cell lineage markers were negative, and with a strong CD56 expression, we needed to exclude blastoid plasmacytoid dendritic cell neoplasm, and that was TCL1A was negative, so that was excluded as well. So this immunophenotype was suggesting that the left-sided lesion was more like a T acute lymphoblastic leukemia, while the right-sided lesion was more compatible with a myeloid acute leukemia. So we needed to really confirm these, because the therapies for these two neoplasm for these two leukemias would be different. So we asked our clinicians to go back to these lesions and go ahead and sample them so we could get some fresh tissue for flow cytometry to really be sure of what we're seeing here. So our flow lab is very good at disaggregating our skin lesions, and we're able to get some fresh cells for flow cytometry. So here we have blasts that are shown in red. They're dim for CD45 expression and show low side scatter. And you could see that the blasts from the left-sided lesion are strongly CD34 positive. The right-sided lesion also has CD34 positive blasts that are variable to dim for CD34 expression, but notably they show no cytoplasmic CD3 expression, while the left-sided lesion has strong cytoplasmic CD3, again consistent with a T-cell lineage here. The right-sided lesion has variable MPO expression with some very strong myeloperoxidase expression, while the left-sided lesion has no MPO. This is just some background autofluorescence, because this is a cell-perforating preparation. And another marker of immaturity, or another marker of B-cell lineage, CD79A, but it could be seen in T-ALL, is positive in the left-sided lesion, but negative in the right-sided lesion. And then similar to what we saw by immunohistology, CD56 and CD7 are positive in both. CD33 are positive in both. CD19 B-cell lineage marker is negative. And then the myeloid lesion was also expressing CD64 and bright HLA-DR. So in summary, the right-sided lesion was more consistent with a myeloid differentiation expressing strong MPO, while the left-sided lesion was more compatible with an early T precursor ALL, because there was expression of cytoplasmic CD3, dim CD5, and also had some myeloid lineage expression. So this was our diagnoses for these would be our diagnoses for these two lesions. However, it didn't quite make sense that this patient would have two acute leukemias simultaneously. So we needed to establish a possible link between these two. So we turned to our molecular techniques. Could these lesions be related? And sure enough, we did TCR gamma gene rearrangement by fragment analysis, looking for clonal peaks. And sure enough, we found a clonal peak in both of these lesions, and the clonal peaks were identical in size, confirming that these lesions are clonally related. We then went on to do our MSK Impact Heme panel. So this is a panel that's slightly different than the solid panel. This panel has 400 genes that are targeted, and again, we're looking at a normal matched sample to exclude any germline variants, so that we're reporting only somatic mutations by this analysis. And here we could see that there were many mutations that were common between these two lesions, again confirming a clonal link. So we have HEV6, WT1, PHF6 mutations that were common to both. And also, if we look at the copy number profile, so the way that the analysis is structured, that we can actually look at the whole genome, looking at abnormalities as either gains or losses between different regions, and we could see that the overall pattern is quite similar. there are certain differences that are found between these two lesions on the two sides. And additionally, you could see that their left-sided lesion had an additional KRAS that wasn't found in the right-sided lesion, and a P10 variant that wasn't found in the right-sided lesion, whereas the right-sided lesion had an NRAS. And as far as the mutational profile is concerned, so PHF6 mutations are most commonly seen in T-ALL, but they can also be seen in therapy-related acute myeloid leukemia. And similarly, WT1 mutations can be seen either in AML or it can occasionally be seen also in T-ALL. And CDK and 2A and 2B alterations are seen in lymphoblastic leukemias. So the fact that we were dealing with an acute leukemia here, we know that leukemias have a wide spectrum of recurrent chromosomal rearrangements, and we actually rely on those to stratify and to classify the patients. And typically, we rely on having a karyotype to be able to adequately perform karyotype analysis and have metaphases. But in this case, the patient has no involvement in the marrow, and so we don't have any fresh tissue to perform a traditional karyotype. But in order to diagnose this acute leukemia, we need to exclude certain recurrent genetic chromosomal abnormalities. So we turn to our NGS RNA-fusion panel, which targets 199 genes, and we evaluated both of these lesions by our Archer panel. And sure enough, both lesions revealed a common fusion between the PCALM and the MLL-T10 genes. This was predicted to be an in-frame fusion of these two genes and involving exon 17 and exon 8 in these. So sure enough, this was clonally linked. So putting all the information together, this patient was diagnosed with a mixed phenotype acute leukemia, T/myeloid, with the PCALM MLL-T10 fusion. This is currently not a WHO-defined category, but this is a recurrent cytogenetic abnormality that can be seen. So the molecular findings in this case confirm that there's a clonal link, even though the immunophenotypes are quite different. At diagnosis, she also had involvement of her CSF because there were abnormal blasts that were seen with a similar immunophenotype detected by flow cytometry. So her disease was predominantly restricted to the skin and CNS. She was treated with an ALL-inspired regimen. She also had intrathecal chemotherapy, and once she achieved complete remission, she underwent, because this is a fairly high-risk patient, she underwent an allogeneic stem cell transplant, and now it's been close to 2 years where she's had no evidence of disease. So just to briefly touch on mixed phenotype acute leukemia, this is a really complex entity. It has heterogeneous clinical presentations. The main feature of this is that the immunophenotypic features are quite difficult to evaluate, and it's quite difficult to establish a single lineage in these lesions. And they also have variable cytogenetic and molecular genetic features. The true incidence of mixed phenotype acute leukemia is unknown, but it's thought that the frequency rate is approximately 3% of all acute leukemias. The diagnosis requires extensive immunophenotyping, and the WHO actually has specific guidelines as far as assigning lineage and which markers are used or which combination of markers are used for designating something as either myeloid lineage, T lineage, or B lineage. And in our case, the right-sided lesion had myeloperoxidase expression, which is enough for myeloid differentiation, and then the other lesion had cytoplasmic CD3 expression, which was enough for T lineage expression. And in addition to that, in order to make a diagnosis of mixed phenotype leukemia, one has to exclude other cytogenetic abnormalities that are defining for specific leukemias. And also it's important to know the patient history so that if the patient was previously treated with cytotoxic or radiation therapy, we frequently see that those kinds of acute myeloid leukemias do have this presentation with a mixed phenotype, so it's important to know the history of the patient. And MDS-related AML can also have, can occasionally have a mixed phenotype leukemic blasts as well. So on the basis of cytogenetic abnormalities, mixed phenotype acute leukemia is also divided into additional subcategories. So for instance, MPAL with the BCR-ABL translocation has a worse prognosis than other MPALs, which is already considered a poor prognosis when it comes to acute leukemias. And also MPAL with the MLL rearrangements, or KMT2A, also share a poor prognosis. And there have been a number of studies looking at different chromosomal abnormalities in mixed phenotype acute leukemia, but those have been identified in much smaller numbers. Overall, however, the majority of mixed phenotype acute leukemias have an abnormal karyotype. So what is PCAM-MLL-T10 fusion? This is a rare but recurrent chromosomal translocation that has been described before. The PCAM gene is found on chromosome 11, and the MLL-T10, also known as AF10, is found on chromosome 10. So PCAM is a phosphatidylinositylclathrin assembly lymphoid myeloid protein. This is involved in endocytosis. It helps to form endosome by participating in clathrin-coated pits, and it also may have a role in iron transport, because in mouse models, introducing point mutations in the PCAM genes led to functional iron deficiency in the mice. It led to a deficiency of growth, so it's thought to play a role in endocytosis-mediated iron transport. MLL-T10 and PCAM is also ubiquitously expressed. MLL-T10, the precise function is not known. It was first identified as another translocation partner with KMT2A, with MLL, and it's expressed in a number of different tissues, including testes, ovaries, thymus, and brain. And the precise function is unknown, but because of its homology and because of some of the structural and functional data, it likely functions as a transcription factor and may be important in chromatin-mediated gene regulation. And in fact, there have been some mouse models of the PCAM-MLL-T10 fusion in trying to induce leukemia, and what's been found in the mouse models that have been described that these mice do develop leukemia, but the onset of leukemia is relatively long, suggesting that there is a need for additional genetic events, that this is enough just for leukemogenesis alone. And interestingly, the leukemic cells that are described in the mice demonstrated both myeloid and lymphoid markers, suggesting that the target of the fusion was multipotent. And similar to some other acute leukemias that disrupt the Hox gene transcriptional cascade, these mice also have Hox gene overexpression, and they likely this fusion likely plays a role in dysregulating the Hox gene-mediated transcriptional cascade, which is important for normal hematopoiesis in all cells in the marrow. So the PCAM-MLL-T10 fusion was first described in T-ALL back in 1996, and since then a number of studies have described patients with this fusion. Recurrently, it's been mostly reported in T-ALL, but a few cases of AML and a few cases of mixed phenotype acute leukemia have been described. Frequently, these patients are also described to have CNS involvement, and overall, what's been described is that they have a poor prognosis, except one study of 14 children showed that at least in patients who have more of a T-AL immunophenotype and using more aggressive chemotherapy, that their prognosis was similar to other T-ALLs. So we decided to look at our own internal experience here at MSK, and we looked back at some of the cases that we've seen. And in the last 24 years, we were able to identify 15 patients. And to date, the literature has described about 140 total patients, but all of those studies range from about 10 to 20 patients. So here we were able to identify 15 patients. And of these 15 patients, we were able to confirm the fusion in 9 of the patients. And predominantly what we're observing is that most of the patients, about 40% of those, have a mixed phenotype acute leukemia rather than the TALL that's predominantly described in the literature. And we were able to perform next-generation sequencing by MSK Impact in 8 of those patients, and the recurrent mutations are shown here, and the majority of them are PHF6 and P10. And this is work by our former fellow, Hamad Tashkandi. So the preliminary conclusions for our study is that these patients tend to have a male predominance. They tend to be younger age for adults, about 35 years. Frequently, they have extramedullary involvement similar to what our patient have, and overall, they have a poor survival. Also, predominantly we see a mixed phenotype acute leukemia with T-cell lineage differentiation, and as I mentioned, PHF6 and P10 mutations are most commonly seen. We think that possibly PCAM-MLL-T10 fusion may genetically define a subset of MPAL with a unique clinical pathologic features, and we're trying to gather more cases to try to identify these. And we're not sure that it's as rare as it seems, because in the past 2 years, I think we've seen about 6 or 7. So we think that maybe we'll be able to gather a few more. So in summary, this case illustrates a unique aleukemic presentation with divergent immunophenotypic features that were linked by genetic markers that we were able to identify by molecular profiling, which really helped to establish an accurate diagnosis and make sure that the patient was treated appropriately. We know that MPAL is a heterogeneous group of leukemias, and as in this case, incorporation of genetics helps to improve our biological understanding and optimize treatment. And lastly, I just want to emphasize this one point, that in our patient, we really didn't have any fresh tissue to be able to karyotype the acute leukemia. So the use of the NGS-based RNA-fusion assay helped to make sure that this wasn't one of the acute leukemias with another recurrent cytogenetic abnormality that would define it as a separate class. So even in cases where there's a lack of fresh tissue, we can use this RNA fusion assay to aid in the diagnosis and to aid in leukemia classification. And again, I just want to acknowledge Hamad Tashkandi, our former fellow, and other members of the molecular pathology, and as well as the Heme Path department and our clinical colleagues. Thank you so much.